Here's the case. So a 60-year-old African-American male with HCV, HIV on antiretroviral therapy, and you can see he's on the bacavir, 3-TC, dolutegravir, doing pretty well, maybe not as much of an immunologic response as you might think, but an undetectable viral load. He comes into clinic complaining of fatigue and some erectile dysfunction and low libido. So he had a DEXA scan which shows osteoporosis, mild osteoporosis, but osteoporosis nonetheless. He has no history of fractures, no occult fractures on plain spine x-rays. His risk factors include a mother with a hip fracture, and his 16% risk of over 10 years for osteoporotic fracture and a 3% risk for hip fracture. He does not have any obstructive urinary symptoms. He has no family history of prostate cancer, and his baseline PSA is 2.0. He has a history of myocardial infarction 10 years prior. He received a stent. He is doing fairly well on, you can see his regimen of atorvastatin, aspirin, losartan, and atenolol. You can see he doesn't have any anginal symptoms. You can see his lipid profile there, which is under reasonable control. On physical examination, his BMI is on the low side at 19, and he has a normal digital rectal examination. From a biochemical testing point of view, as I said, PSA was 2, so say it's 1.5. We'll split the difference. At 8 a.m., he had the following testosterone labs. He had a total testosterone of 422. And you can see the other units for non-US folks. His free testosterone, and this was calculated free testosterone using the Vermeulen equation, was quite low at 17. And his LH and FSH were elevated at 18 and 35, respectively. So the question to the debaters is, would you recommend testosterone replacement in this man? And Dr. Dobs is going to take the pro side.
So I am taking the side that this man should be treated with testosterone, and the reason is that he is symptomatic for conditions often seen in men with low circulating testosterone concentrations. His hypogonadism is common in HIV-infected men, and the pathophysiology is often known. The benefit outweighs the risk. He can be monitored for any potential risk-benefit, and the GU conditions, which neither one of us are really going to discuss, is essentially a non-issue. And has, although everyone was very interested in this about 10 years ago, it seems very clear that testosterone does not cause or even worsen prostate cancer. So what I'd like to talk about this afternoon is a quick overview of the pathophysiology and epidemiology of male hypogonadism in general and in HIV disease. Then talk about some common metabolic problems in HIV infection and its relationship to testosterone therapy, and then finally discuss some of the potential risks. So just so that we're all on the same page, on the left here is the hypothalamic pituitary testicular axis. Here's the hypothalamus, which produces gonadotropin-releasing hormone, GnRH. This stimulates the pituitary gland to make luteinizing hormone LH and follicle-stimulating hormone FSH, and this stimulates the testes to make testosterone and sperm. So on the right side is something that's extremely important as well, and that is the fact that when you order a total testosterone, you're really getting a combination of the testosterone that is tightly bound to sex hormone-binding globulin, SHBG, and that which is weakly bound to albumin, and only a small percentage actually free and available to bind to the testosterone receptor. Now, the prevalence of hypogonadism has been reported in many ways all over the place. In the pre-HART era, this data show anywhere from 16 to 65%. Most people would say it is less in the post-HART era, but even in that situation, the results are 3 to 54%. Now, most recently, we published something looking at the MAX cohort, the multi-center AIDS cohort study, and in here we found that hypogonadism was seen in 24% of HIV-infected men. So again, this is not AIDS, this is just HIV infection. Some of these were on treatment, some of these men were not on treatment, versus 7.8% of HIV uninfected men. So it's still common, it's still out there for various reasons. So one of the issues that I do want to emphasize is the issue of free testosterone being so important in this particular population. And here you see the free testosterone level over time based on HIV serostatus. In the blue are those men who are HIV negative, and in the red are HIV positive men, and this is years since starting heart. So I want you to see a few things. The first is that free testosterone does decline in both populations, and in fact, free testosterone will decline 1.1% per year. And that really there wasn't that even much difference, except that the HIV positive started out negative and then continued to fall as the years passed. Now, I want to emphasize the free testosterone issue because when you look at sex hormone binding globulin, SHBG, it's really a very complicated globulin. We don't understand too much of it yet. It is a binding protein, and it turns out that it is higher as men get older. So that's why it's so important to look at the free testosterone, because looking at the total can be misleading. SHBG is elevated in men who are older. It's also elevated in men who are HIV positive. They seem to have a lot of proteins and antibodies floating around, which can make the total testosterone very misleading. And in fact, the case that Todd showed was a gentleman that looked like he had a normal total testosterone, but in further analysis, his free was clearly low. And we saw this in a recent publication, again in the MAX, in which we looked at men who were not treated with testosterone and found that 32%, I'm sorry, let's get back, 32% of these men had a normal total testosterone, but a low free testosterone, compared to, there was a few hypogonadal men in the HIV uninfected population, but in that situation, they were truly normal in both. So again, a free testosterone is crucial in making the diagnosis of male hypogonadism in a HIV-infected population. All right, so one issue is the laboratory test. The other important issue is what are the signs and symptoms. And many of these are relatively specific. So what I'm talking about here is reduced or diminished sexual development or libido, reduced erectile dysfunction, decreased fertility, while increased problem is that of an increase in bone mineral, a reduction in bone mineral density, fragility fractures, hot flashes, and sweat. So in some ways, these are very suggestive that there's a testosterone problem going on, as there was in this gentleman who had sexual dysfunction and a reduced bone density. But as in many endocrine disorders, some of this is less specific, and we sort of can dance around this. It's almost like all these patients that come to me who are obese and they say, oh, I must have hypothyroidism. Well, that really is not the case because obesity and hypothyroidism is very nonspecific. So the less specific issues in this population is reduced energy, mood, concentration, memory, physical performance, muscle bulk, and a sense of increased body fat. This can be a finding seen in hypogonadism, but obviously it's very nonspecific. So the Endocrine Society recommendations is something that really could be applied in the HIV population as well. They keyed in on the fact that there must be morning samples because there's a circadian rhythm to testosterone, and I've already said that a free testosterone is the best test here. There needs to be this laboratory diagnosis as well as signs and symptoms of hypogonadism. One should not treat just on one or the other. The other is they really emphasize the issue of attempting to find an etiology. And when there was a clear etiology, you could feel much more comfortable in treating HIV-positive men. And in this patient situation, the FSH and LH were elevated, which suggests that there's a problem at the level of the testes. So again, you feel much more comfortable in treating this kind of gentleman. And then the last point is that it's reasonable to say, we'll give you a trial of testosterone, see whether or not your symptoms improve, because we can always stop it. So the reason I say that the HIV, the hypogonadism and the mechanism can be clear is that there are some very understood etiologies, infiltrative infections of the pituitary or the testes. Medications, glucocorticoids seem to suppress the pituitary as well as the ACTH. Opioids very commonly result in suppression of that axis. Cancer therapies, chemotherapy, radiation therapy, and certainly severe weight loss is a clear mechanism for hypogonadism. We're not as clear about some of the other mechanisms, although we know they're associated with HIV disease, such as end-stage renal disease, type 2 diabetes, COPD, co-infection with hepatitis, osteoporosis, and low fractures rate. Now, I do want to emphasize the fact that low testosterone does coexist with many other problems. Some have argued it's a marker for other disease. And here you see there's with an increase in comorbidities on the x-axis, there's a greater likelihood that these men are hypogonadal. Now, my colleague will likely say, we shouldn't treat because it's really the comorbidities. But I would take the stance that why should we leave a man who has diabetes or a man who has osteoporosis to be hypogonadal if he's symptomatic? We should treat the underlying disease, but in the meantime, while he's getting better from his HIV cachexia, while he's getting better from his chemotherapy, that he needs and should be treated with testosterone. And here, similar is the issue of a frailty index. Again, this is from the max cohort. Testosterone levels will fall, will be lower in men who seem to be more frail. So it goes hand in hand and oftentimes cannot be separated. Now, some of the big hoopla, what's the word? Hoo-ha-ha or something that has, what is that? Hoopla, that has happened with testosterone is the fact that there's been so much more treatment and use of testosterone over the years. And the FDA has gotten quite concerned about this. And you see here the increase in testosterone prescriptions that went up to 2013. And this was primary care. In red is urology, and in blue and in green are endocrinologists. So primary care physicians are writing a great deal of prescriptions. Now, this did significantly change in 2014 when the FDA said that we were overusing testosterone, and it dropped about 25%, but it's really leveling off. And I think that it was good. I think that testosterone was likely overused in men in whom there was a poor diagnosis and a poor understanding. And we see that testosterone use is still quite common, though, in an HIV population. And here is age groups, and in the darker bars are men who are HIV positive, and in the lighter bars are those who are HIV negative, and based on different age groups. And what you see that about 25% of men who are less than 60 are treated with testosterone, for the total of 17% of HIV-positive men. So it's still being used quite frequently in our population, and in fact, I think perhaps rightly so. So the interim conclusion now is that low testosterone is common in HIV disease. The symptoms, however nonspecific, are common in our population, and the mechanism is often clear as to why a man has a problem, and that testosterone therapy is commonly used in HIV-infected men. So what I'd like to talk about now is some of the metabolic problems in HIV disease and how that might be related to the hypogonadism and testosterone therapy. These are some of the common problems that are seen in metabolic problems that are seen: decreased bone density, diabetes, obesity, increased abdominal girth, accelerated heart disease, and sexual dysfunction. So I'll first talk about osteopenia and osteoporosis because, again, this gentleman had this case. This is a meta-analysis that was done by Todd Brown, our moderator, in which he looked at the prevalence of osteopenia and osteoporosis in 3 different groups. And here's the odds ratio being 1, so anything to the right means there's an increased odds of this happening. In this, it's HIV versus HIV negative, so truly HIV men are more likely to have osteopenia or osteoporosis. This is treated versus untreated, so even in the treated state, they tend to have a greater odds of having bone disease. And then the last here is the use of protease inhibitors, and even here, there is an increased risk of having osteopenia or osteoporosis. So this would be something very clearly as a reason to treat this population. And there have been some studies that have given testosterone to HIV-infected men who in this situation had wasting, and they looked at the lumbar spine, bone mineral density, and testosterone had a very nice effect to increase bone mineral density. There are testosterone receptors, just like there are estrogen receptors in the bone, and we certainly know that estrogen maintains bone mineral density, and so does testosterone. Diabetes is another common metabolic problem. It is about 4 times increased risk of developing diabetes in heart-treated men, and this is a study that Dr. Brown published with a group of us in the MAX data to show that HIV positive people have an increased risk of being diabetes-free. Now, I'm not making the statement that testosterone is going to cure diabetes at all. Obviously, one has to be aggressive about treating the diabetes, but there have been several studies to show that men who take testosterone actually do better metabolically. They seem to lose body weight. And here you see over a 12-month period, they lose some weight, and they lose some weight circumference. And this in some ways makes sense, because if you give a man testosterone or you give a woman testosterone, it will increase her muscle mass and decrease her fat mass, and then she could win in the Olympics. Okay. And there have been a few studies that looked at body composition in men who have HIV infected. And here, this is the percent change from baseline. This is in the open is placebo, in the hatched is testosterone. Men who were given testosterone had an increase in fat-free mass, a reduction in their fat mass. They did gain weight, because muscle does put on weight, and there was a reduction in their total body fat. And in some studies, this has translated into strength. So here is a study done by Dr. Bassine's group, where they looked at strength in a population that had no exercise but was given testosterone, and there was an increase in strength. And exercise certainly did the trick alone, so I'm not advocating giving testosterone just for the sake of it, but exercise increased muscle mass, and so did exercise plus testosterone. Now, one of the key questions that my opponent will be harping on is about the atherosclerosis. And there's been really very interesting data that have come out over the last few years about the premature atherosclerosis that can be seen in HIV men. And what you see here coming out of MAX data with Wendy Post as the lead investigator, an increased atherosclerosis that is seen in HIV, about 61% greater risk of carotid artery plaque, and this is developed over a 7-year period. So here, HIV infected are in the dark bar, HIV uninfected are in the light, and what you see is that here they were pretty equal at baseline, although the HIV was slightly more. But if you follow these patients over a 7-year period, the HIV-infected men are much more likely to have a plaque develop compared to the HIV uninfected. So this is any plaque, and this is a formation of new plaque that was significantly different. The HIV-positive men were more likely to develop plaque. So this is just one of several studies that have highlighted the fact that HIV-positive men are more likely to have heart disease, as was our patient here that had an MI. So where does testosterone fit into this as a potential risk? Well, the first thing is that, there is some biological plausibility here, and that's why we have to take this very seriously. There can be an increase in hematocrit, there can be a drop in HDL, changes in platelet aggregation, sodium retention can occur because it is a steroid, smooth muscle proliferation, and an increase in VCAM expression. But the other side of the coin is there could be actual benefit from giving testosterone on cardiovascular disease. One reason is that it's converted to estrogen, and estrogen will vasodilate. The other is that it changes body composition, and in changing body composition, it will decrease some of the visceral fat. There can be some increase in vascular reactivity, and there's also a few studies to show shortening of the QT interval. So Dr. Bessaria will go into detail with some of these studies, but this is an example of a study that got a great deal of press and led to the FDA hearing. And what they found in this study is using large data sets, testosterone use was associated with an increase in all-cause mortality. And this is the no testosterone therapy. This is percentage survival. So those men who were given testosterone had a decreased survival compared to men who were not given testosterone. So again, this was very important. It was based on very large data sets. But the problem with large data sets is that everybody is really quite different. And what you see here in the criticism of several of these studies is that there was absolutely no randomization. You don't know who got it and why they got the testosterone. And it turned out that in some studies, only 60% even had documentation of having the low testosterone, so perhaps they should never even have been treated. Many of them had insufficient treatment. At the end of the day, their levels were a total of 175 to 335, so that maybe they were hypogonadal the whole time, even after they were treated and after they may have had the event. And so not only was it at post, but really this poor documentation of both pre and post. How long were they really on it? Were they really compliant with taking the medications? So there have been, just as there have been, got all that press about the risk, there's been many studies that have put this together to say there's really very little risk of taking testosterone. In fact, there may be some benefit. Now, this is an extreme case, but an interesting case. And these were men who had androgen deprivation therapy for prostate cancer. And it turns out that their hazard ratio of many of the metabolic diseases we're talking about actually was elevated. So men who are castrated, medical castration, were more likely to have diabetes, more likely to have incident coronary heart disease, an MI, a stroke, or cardiac death. Now, this is a severe case, meaning it's a full medical castration, but nonetheless, they had an increased risk of these changes. In cases of non-castration and just a hypogonadal population, in a meta-analysis done by Arugio, it turns out that, again, most of the studies show that all-cause mortality was actually worse in those men who were hypogonadal. We did some analysis on the ERIC cohort, which is a large atherosclerosis risk in communities study. These people were prone to get heart disease, and it turned out testosterone just didn't make a difference either way. And most recently, we've been looking at the issue of free testosterone and its relationship to cardiovascular disease in an HIV population, and found it just didn't make a difference. So the free testosterone was lower in HIV-infected men, but unrelated to coronary calcium. The adjusted mean log free testosterone, again, was lower, and equivalent to, in fact, 13 years, equivalent to the free testosterone of an HIV uninfected man who was 13 years older, so significantly lower testosterone levels, but there was no relationship between the free testosterone to any measure of atherosclerosis, whether it be coronary calcium or intermedial thickness. Now, I don't want to give the impression that it's benign. We're very concerned about hematocrit, and most HIV-infected men do take injectable testosterone. Injectable testosterone is more likely to cause an increase in hematocrit, so this is something that does need to be monitored carefully. In looking at some large prospective trials, this is women and men, it turns out there's an increased risk of a hazard ratio of having mortality in those men who have very low hematocrits, and also those men who have very high hematocrit. So it is important to monitor the men frequently and to change therapies if needed. So my conclusion is that, yes, this gentleman should be treated. Men with HIV disease are more likely to have low testosterone, especially the low free testosterones. Testosterone deficiency is associated with many of the chronic diseases that we see in HIV-positive men, such as diabetes, obesity, chronic disease. We need to treat that underlying condition. We may choose to stop the testosterone if they recover from their, let's say, HIV wasting syndrome or their chemotherapy. But we should treat if the levels are low. Oh, gosh. Can you get me back there? I'm sorry. I keep pressing the wrong buttons here. We need to treat if the levels are truly low and if a man has symptoms. And that testosterone therapy may or may not help the underlying condition, but there's no data to say that the HIV-infected men are at greater risk for from testosterone therapy. Okay, thank you so much.